let's go with the questions. We have several questions. So let's discuss in a very informal way today. No need to be very formal. So I think these things are mostly actually from the wards, but we see these are not new kind of things. So we have here a 65-year-old man presented with acute dyspnea. He has had recurrent chest pain and found to have triple vessel disease, awaiting CABG. And 2 weeks ago, he was admitted with acute chest pain. This is a very common thing because CABG has a very good pretty long waiting list, you know. So therefore, I am sure as students, you have seen so many patients in between who have already known to have triple vessel disease and waiting for various procedures are being admitted with acute pain. So it's a very common scenario for us. Nowadays, we don't get this very new patient coming first with, you know, that you need to make a diagnosis, but already the patient has had a diagnosis and already the patient has had some form of treatment and the patient is in midway of disease and you face in such a situation. So therefore, this patient is not an uncommon thing, and observations and the ETC has revealed a heart rate of 110, blood pressure 90/70, with cold peripheries, and oxygen saturation of 90, and about GCS was 15. He was struggling to sit up. Why do you think he is struggling to sit up?
Due to dyspnea.
Very dyspneic. He is probably orthopneic, no? Probably orthopneic. Have you seen people like that, you know, struggling to breathe, very restless in the ward settings? With problems in the heart? I'm sure you have. So jugular venous pressure was up to the jaw. Chest examination showed bilateral crackles, right? So what do you think this patient is currently having? What is the acute problem that has led to has been recently admitted as well? We don't know the cause. What do you think is the cause?
Pulmonary edema due to acute heart failure.
Very good. Pulmonary edema due to acute heart failure, right? In a patient who is known to have coronary artery disease, isn't it? Anything else that is important? What do you think? This pulmonary edema is serious? Do you think it is serious?
Yes.
Why? Why?
Saturation is oxygen saturation 90.
We have evidence here. Patient is hypoxic, isn't it? He is struggling, and then he's tachycardic and he's hypotensive, isn't it? He has cold peripheries. What does that mean? With the blood pressure of 90/70 and cold peripheries, he is in
poor peripheral perfusion.
Poor peripheral perfusion. So this is a patient in completely, he has acute heart failure and he is probably in cardiac shock with acute pulmonary. Right? Is it clear up to that?
Yes, ma'am.
Right. Okay. So now let's go with the questions. So he has been already on drugs. We know that ASA is acetyl salicylic acid, aspirin 150, insulin twice a day. So we know he's a diabetic. Telmisartan is an ARB. And metoprolol succinate is a beta blocker. And he's on sublingual GTN. And spironolactone is a mineralocorticoid antagonist. You know all those things, plus rosuvastatin and furosemide already. He is now already on medications for what are the conditions that he is on medications for most likely here? What are these medications? Other students also can open up mics because it is it's very distressing for me to speak to a, you know, there's no one here. I'm speaking to a screen, right? Yes. So he is being treated for diabetes,
dyslipidemia,
coronary artery disease, and spironolactone is given for what? Spironolactone?
Heart failure.
Heart failure, chronic heart.
Yeah, already has chronic heart failure. What do you think is the origin of this disease is now? What is the cause of this heart failure? Most likely.
Ischemic heart disease.
Most likely
Ischemic heart disease.
definitely ischemic heart disease. He has triple vessel disease and he needs specific treatment. So he is a complicated patient, right? Okay. So most likely cause of the breathlessness, you said that acute heart failure causing acute pulmonary edema, right? So what urgent investigations and treatment is indicated is the next question. So this kind of patient is very difficult to put on to the bed also. So probably you will have to prop him up and start some therapy before we actually settle the patient. So what therapy would you immediately start here before doing ECGs and all those things? What do you do?
Oxygen.
Oxygen therapy.
You have to put on a high flow oxygen, not with nasal cannulas. So therefore you might have to put you have to put on high flow oxygen and probably prop him up, isn't it? And quickly connect him to the monitor, isn't it? Right. Do you have to be ready with something else? I'm just imagining that we are in the ward. So what else can happen now? What do you do now? He's got you know that he has pulmonary edema. What do we do now? He needs treatment, isn't it? He needs treatment, right?
IV diuretic.
IV diuretic. Immediately we will have to install a cannula and put on a what kind of diuretic would you use? He's already yes.
IV furosemide 50 milligrams.
IV furosemide comes in 40 milligrams. So you can give 40, 80, 120 or even high dose, doesn't really matter, right? So probably you might have to give about 80 milligrams here for this patient. And while doing that, you might have to do a few things. So probably he's drowning himself with fluid inside his lungs now. So he's drowning himself already. So very important that we need to check on his oxygen saturation and make sure that he gets adequate oxygenation. If there's adequate oxygenation doesn't happen, what will happen to him? So what will happen to him if there's no real oxygen happening? What will happen to him?
Hypoxia.
Yeah, hypoxia will induce
Type 1 respiratory failure.
Yeah, hypoxia will cause death or cardiac arrhythmia or confusion, coma, organ damage. All those things will happen. So immediately you need to check on to his oxygenation. So that's the most important thing. So you have identified that. So then now we have right. So you have given furosemide and you have given now oxygen, and then the patient is propped up and the patient is waiting, and then I have given you the ECG. So while doing that, what does this show? What does ECG show? Is it in sinus rhythm? You have already had this ECG, so therefore you must be knowing that. Did you receive the questions beforehand?
Yes, madam.
Right. So what does the ECG show? You don't have to be very worried about these things, because what you really see here is you can see that the patient is in sinus rhythm, isn't it? And there's tachycardia going on, and the ST segment is
Elevated.
Depressed.
Yes, it's not elevated here. It is pretty much depressed. You can see the ST segment here is depressed about 5 millimeters, right? Here. So actually, these are the inferior leads, the lead 2, lead 3, and AVF. Real ST depressions are seen. Not only that, even the septal leads are also V3, V4. So we don't have to worry too much. This looks like a very diffuse ischemia. Very diffuse ischemia. Probably one of the main coronaries have got blocked. We know already that he has triple vessel disease. So what is the most likely cause of, as you said, it is probably acute coronary syndrome. Acute coronary syndrome. So now we found the cause of this, and then this is his chest X-ray. What does it show? Is this a normal looking?
Signs.
Yes.
Signs of pulmonary edema.
Signs of pulmonary edema. So what are the signs of pulmonary edema seen here?
Back pain sign.
Almost like a back pain, isn't it? Heart shadow is barely visible. This is the heart shadow, and heart shadow, the cardiothoracic diameter is also elevated, isn't it? Cardiothoracic diameter is elevated, and you can see a lot of pulmonary congestion starting from the hilar region. So that is why you call it a bat wing shadow, isn't it? Bat wing shadow. There's not only that, there's a lot of interstitial edema in the other regions also, and you can see the upper lobe blood diversion here. You can see these vasculature is much more than the other. So therefore, there's a lot of upper lobe blood diversion. In addition, what else can this X-ray is not showing, but in addition, what are the other features of heart failure? In addition,
Pleural effusion.
effusion. Yeah, what did you say there? Pleural
Maybe like
yeah. So pleural effusion. Yes.
curly B line.
Curly B lines, curly lines, B, C, A. There are so many lines. So curly B lines are the ones which are seen actually horizontally, which is not very clearly seen here. But curly lines may be there. Maybe this is a curly line, right? So curly lines could be there, right? And sometimes certain fissures will collect fluid like a vanishing tumor of the lung. If you know, there are interfissural fluids also, not only in this. Not only in the pleural spaces. So this patient seems to be having a florid pulmonary edema. So what we are trying to do is getting rid of this fluid out of his lungs by giving a loop diuretic, isn't it? By giving a potent diuretic, you are going to get rid of the fluid from the lungs. For that, what does he need to have? How do you know whether this is working or not? How do you know whether it's working or not?
Increase urine output after
Increase urine output, exactly. Increase urine output will be seen after about 5 to 10 minutes later. The patient should pass urine. This kind of patient, do they have renal problems also? Especially when they have this kind of pulmonary edema. This patient had diabetes, hypertension. So,
They do.
yes? Yes? So what can he have? Can the renal function be already abnormal?
Could be
Yeah,
abnormal,
yes.
but we can go through with the patient. Patient condition sometimes improve with the treatment.
Yes, patient could be having a renal impairment also. So always you have to be very careful. So you can't at times as you wish the furosemide will not work. Furosemide might not work, right? Even if you give a very high dose, it might not work. So always you have to keep in mind and check on the urine output and probably do a few investigations also. So now let's look at the question back again. Right, now you can tell what urgent investigations are indicated. Now you can answer the question. We have the ECG and the X-ray, right? So start from there.
Transthoracic echocardiogram to confirm the diagnosis.
Yeah, okay, transthoracic echocardiogram. So you might need a bedside echo, no? In that case, bedside echo. Okay, bedside echo. Bedside echo. What do you think it will show?
Reduce ejection fraction.
Yeah, extremely reduced ejection fraction, and the LV dysfunction will be shown, isn't it? Left ventricle maybe, or both ventricles may not be contracting well, no? Not contracting well, and very reduced ejection fraction, as you said. Okay, what are the other investigations?
Cardiac
Cardiac
enzymes.
biopsies like troponin.
Exactly, cardiac enzymes, because you have already seen this patient has acute coronary ischemia going on. So probably cardiac enzymes like a troponins you will need urgently, no? So say if troponins are elevated, what do we diagnose here? Troponins could be normal or elevated. Elevated, it may be even a non-STEMI, isn't it? The STs were not elevated, no, so therefore it could be non-STEMI, but it could be just a unstable angina even, isn't it? Any both could be, but we didn't see any ST elevations here, so probably it could be an non-STEMI or a unstable angina. So both are under acute coronary syndrome, right? So cardiac enzyme. What are the other investigations that you would like to have?
Serum creatinine to rule out the diabetic nephropathy as patient has diabetes.
Creatinine, yeah. Along with creatinine is another substance very important to manage this patient. Extremely.
Serum
Yes. Serum.
Electrolyte.
Electrolytes. It's very important. So what can happen? What are the abnormalities in electrolytes in heart failure?
Hyperkalemia.
Hyperkalemia. You are thinking
Hyponatremia.
hyponatremia, hyperkalemia, both possible, isn't it? Electrolyte disturbance are very likely. When there are a lot of water inside, the patient can have a dilutional hyponatremia. It's a very well-known cause of very heart failure. So electrolytes are very important. Anything else?
Serum BNP level.
Yeah, serum BNP level, if it is available, BNP level will tell that the patient has, this is the cause of the,
Heart failure.
yes, it is heart failure, nothing else, isn't it? Not any other cause. But if there's any difficulty in differentiating, BNP level will be useful, right? Right? Any other?
Thyroid function test.
Thyroid function might need, maybe not so urgently right now, but thyroid function. More than that, anything, this diabetic, renal disease, what are the important things actually? Correct.
Blood count.
Blood sugar.
Full blood count, random blood sugar.
Full blood count, random blood sugar. So we have some investigations listed here. So you want an echo. Sometimes lung ultrasound also possible to see this pulmonary congestion because it is available in our ETC. We can do that as well. So those are the basic investigation. If you have difficulties in kind of differentiating, you might ask for further investigations. Probably you might need a liver function test also because hepatic congestion also can happen. So don't forget the urea and electrolytes, which are the most important to manage this condition. So urgent investigations we are listed. Now, how would you treat? You have already listed the two. So blood pressure is 90/70. You have given a high dose of diuretic also. So what are the medications? Now you have given this and you're waiting, and then probably what else need to be done here?
And drops.
You think he might need an inotrope, right? Okay. What kind of blood pressures are we think of starting for an inotrope? Maybe systolic blood pressure 90, right? Below systolic blood pressure 90 will be problems with perfusion of organs. So other organs also will fail. So we have to maintain a blood pressure of 90 to 100 at least, right? So that is our goal, right? So we have to maintain that. With that furosemide, blood pressure might drop a little further, and you might have to go for an inotrope, right? So what kind of inotropes are available to manage acute heart failure, and how would you choose these things?
And dobutamine, noradrenaline, depend on the blood pressure.
Depending on the blood pressure, either dobutamine or dopamine or noradrenaline, those are the things which are available. That generally we try to use dobutamine, but dobutamine has not much of pressure effect. It can't raise the blood pressure more than 10 or 15, right? So for that, we might have to go for this patient has only 90 systolic blood pressure. So depending on, probably we can use dopamine for this patient. In dopamine, I'm sure you know the dopamine, dobutamine, and noradrenaline, their actions. And when dopamine has very different actions, when it is very low, it has a renal effect, and we call it often renal dose of dopamine. And then the moderate effect, then you have the cardiovascular, and in high doses, different effects. So I'm sure you know the beta and alpha effects of dopamine. So therefore, if the blood pressure is less than 80, it's difficult to raise blood pressure with dopamine. Then you might dobutamine, because dobutamine is a milder drug, so you might have to go for dopamine. So you are going to use a pressor. Noradrenaline is generally used for which shock? Which kind of shock?
Septic shock.
Generally septic shock, because there's effects also. So therefore, noradrenaline also could be used in very severe situations, right? So right, what other medications would you consider here? Anything else? So let's
IVGTN.
IVGTN. IVGTN problem would be this patient's problem.
Hypotension.
Yeah, hypotension could be a problem. Hypotension could be a problem, but you may be right because sometimes in a very severe situation, you have to reduce the preload, right? You have to reduce the preload, so you might have to use both, right? So you might have to use both in a practical situation. You have to use a nitrate and an inotrope both, but these are very special situations, and you might not. These are special cardiology setting situations. So nitrate to reduce the preload if it is very resistant, yes. So any other, now we have actually discussed a lot of pharmacology. The patient's oxygenation you are not happy about because of the pulmonary edema. The patient is hypoxic. Any other investigation that is needed right now?
ABG.
ABG, of course, ABG. You will need ABG, and then what do you do with the ABG? So what can be considered? What are you going to consider with the ABG? This kind of patient with very unstable situation might become very hypoxic, and the patient might have a acute arrhythmia and a cardiac arrest, right? So therefore your all the resuscitation has to be also be ready, and the patient oxygenation is not good. What do we do normally in the ward in acute pulmonary edema as a non-pharmacological measure?
Non-invasive ventilation using CPAP.
Absolutely, you might have to use CPAP, right? You might have to use CPAP, right? Because it has a positive pressure, it will be effective for pulmonary edema as well, right? Or else, if the patient is getting exhausted, can the CPAP work? For CPAP, the patient will have to breathe and have a respiratory effort, isn't it? So the patient is getting progressively fatigued. If the patient is getting progressively fatigued, what do you have to do?
Using by
Sorry?
Intubation.
You might have to do intubation and consider about ventilation, right? And you might have to do that. So now this patient also has acute coronary syndrome. So does it need treatment? Does it need treatment, say even unstable angina, or now you saw the ECG. ECG is looking very scary, very lot of ST depressions are there. So therefore you might have to use, what drug would you use in acute coronary syndrome?
Aspirin.
He's already on all those.
Aspirin, clopidogrel.
All those things he's already on.
Cutaneous enoxaparin.
Yeah, he needs definitely. Yeah, he needs definitely enoxaparin. He needs treatment for the acute coronary syndrome. Now, look at this patient's drugs chart. There are a few things that we need. He is on metoprolol 100 milligram daily, and he has florid pulmonary edema. What are your thoughts on that?
Beta blockers can precipitate pulmonary edema.
Yeah. Are beta blockers also the treatment of heart failure?
Yes, but not in acute heart failure.
Yeah, that's a very good thought. So not in acute heart failure, because the patient might need a temporary withdrawal. But remember, temporary withdrawal will aggravate the coronary artery disease, because rebound angina is very well known phenomenon in beta blocker withdrawal. And also for heart failure also, treatment is beta blocker. Now you are withdrawing. So therefore you have to be very careful, but maybe temporarily withhold. I would use that word, temporarily withhold, and reinstitute as soon as it is under control. So if it is, some people just leave it alone, some people reduce the dose, some people withdraw it. Now what the evidence says, when you withdraw it, actually the mortality is higher if you have acute coronary syndrome and pulmonary edema. Beta blocker withdrawal is not so good. That's what the pooled evidence say. But in practical situations, you might have to temporarily withdraw. Otherwise, you cannot control the heart failure and the patient will die of heart failure. So therefore, it also has to be considered in this situation, right? So now, would you continue the spironolactone, mineralocorticoid antagonist? Yes. Would you continue?
Temporarily withdraw because in heart failure it is not
Hyperkalemia.
So hyperkalemia, if hyperkalemia happens, what are the two drugs here which are dangerous to continue if there's hyperkalemia?
Spironolactone.
Telmisartan.
And telmisartan.
Telmisartan.
AC inhibitors.
Right. So what? So therefore, those we are not going to stop it definitely, but you have to be checking the electrolytes, and if the potassium is above 5, you might have take one out, right? So it depends on. And other thing is, if the creatinine is also progressively rising, then you have to be very careful with these drugs. So we have to be cautious. So aspirin, insulin, maybe we continue telmisartan, metoprolol, we might temporarily withhold, right? Spironolactone, try to continue unless there's severe hyperkalemia. Rosuvastatin, continue. Yes, right?
Yes.
Yeah, all those things have to be continued. So now we have this patient with acute coronary syndrome, and then treatment wise, we have discussed. Are there any other new therapies available? Any other patients who are very resistant, which have really pump failure? Pump failure. Yes?
Ivabradine and androsin.
Ivabradine is used for people whose heart rate cannot be controlled with beta blocker alone, because that is another form of a blocking drug, slows heart rate. So ivabradine is used generally for people who have stable heart failure, whose heart rate cannot be controlled with a beta blocker alone. So ivabradine is not useful in this situation. I'm just asking for more innovative therapy. We are having this case.
Intra-arterial balloon pump.
Yeah, intra-arterial balloon pump might be needed for this patient. Intra-arterial balloon pump for temporary pump failure, isn't it? So temporary pump failure, he might need a intra-arterial balloon pump, right? Or some other left ventricular assisted device till what? Till what time? Why are we doing all these things, and how long does he need these things? These are all temporary measures. So what does he really need? What does your patient with these problems really need? What does he really need? He really needs some revascularization, isn't it? You are just buying time. You are just buying time by acutely sorting him out. So in summary, this patient will be needing high flow oxygen and then loop diuretic, withholding of beta blocker temporarily, and depending on the blood pressure, you are going to use a inotrope, right? You are going to use a inotrope, either a dobutamine if the blood pressure is not so bad, dopamine if you need a little higher, and if very low down, you might have to use noradrenaline, right? So you are going to keep up the blood pressure up and then treat the acute coronary syndrome. And if the patient is still resistant with diuretic is not working, you are going to combine. You have to give a vasodilator. Somebody always said nitrate or nitroprusside to reduce the preload. And if these things are not working for his oxygenation, he might need the form of ventilation. If he is well and if he can breathe, then if he's breathing, you might have to try a CPAP if it's not so bad. But if he's now getting fatigued, you might have to now need to ventilate the patient, right? At the same time, you have to monitor a lot of things like the creatinine, urea, electrolytes, and then prepare for treating arrhythmias and ready for a shock, isn't it? Be ready for and also treat the coronary artery disease temporarily with the heparin, but permanent treatment has to be now expedited, isn't it? expedited. Right. Now you can ask questions which you have regarding this case.
Madam, I have a question.
Hmm.
Madam, regarding this patient ECG, madam.
Hmm.
This patient ECG shows, madam, widespread ST depression in AVR and V1 ST elevation.
I thought you would ask that question. Right? I thought someone will ask that question. I am glad. So that that looks like it has an extended AVR is a right-sided lead. V1 is a septal right. So probably it's extended to right ventricle. Right?
Yes, I thought diagnosed of left main coronary artery occlusion
Yeah,
and
it's left main coronary artery occlusion. It's a left main coronary artery occlusion. You are right.
So madam, regarding that pulmonary edema part, immediately we have to attend that left main coronary artery part.
Okay. Yes. Yes.
So for that we need urgent angiography or something.
Absolutely. So angiography is already done, and we know that he is waiting for. He has not only a main coronary artery disease, he has triple vessel disease, waiting for 3 ABG. So what you can say is, it looks like from that ECG, looks like that you mean that you want to stent that right now. Is that what you want to say?
Yes, in immediate management, I thought first thing was to do a angiogram and invalid testing.
Yes, that's a good answer. Very good answer. If the patient's data was less, the data was not given. So we have already given that data, right? So we have already given that data. So in another case, definitely yes, he has already had angiogram, right? So probably, as you say, that the main coronary needs attending. That is true.
Okay, madam. Thank you.
Yeah. Yes. You have to remember, all those lesions are not very stentable. Some of these things are not very stentable, right? When you need more than 3-4 stents, it's not possible. Also, certain lesions like long lesions are not stentable. So it depends on how bad the lesion is and how the physical the characteristics of the stenosis, right? So in an urgent patient who has come fresh like this, probably he needs definite stenting. Okay. So let's move on to the second question. So precipitants, please don't forget the basics. Now, why heart failure precipitates, acutely decompensates, you need to know. So in our patient, we thought it could be ischemic heart disease, right? But sometimes acutely valves can get damaged, like ruptured sinus of Valsalva, where you can get acute aortic regurgitation, or else you can have mitral papillary muscle ruptures and acute mitral regurgitation. So valvular dysfunction also can happen because of the ischemia, right? So therefore, don't forget that to auscultate, it's very important, right? And then fluid overload is a cause, like in a renal disease, maybe intravenous fluids given for some other illness can push the patient to acute pulmonary edema. And severe hypertension again can lead to acute pulmonary edema. Progressive renal worsening and reduction of urine output, maybe superadded pyelonephritis, right? And temporarily shutdown of the kidneys can cause acute decompensation. So please don't forget these components to look for. It's very important that we check for these things, right? For the reversible, certain things are reversible. Right, so these are the precipitating factors. I am sure these are, you already know, certain precipitants like NSAIDs, right, arrhythmias, some of these, uncontrolled hypertension, anemia, stress cardiomyopathy, have you heard of? Yes? Okay. Stress cardiomyopathy, Takotsubo cardiomyopathy, where you get apical ballooning, right? Apical ballooning and worsening of heart failure during periods of extreme stress. So those are the precipitants. And just to mention few things, now this is a useful thing because we really now call every heart failure is not the same, right? You have the warm and wet and the cold and wet. Now our patient had a lot of congestion and hypotension, right? Congestion and hypotension. So congestion and hypotension, this patient need the diuretic and an inotrope both. Warm and wet means there's no blood pressure drop, but congested. So this kind of person can do with the preload reduction like a nitroprusside or a nitrate, right? So these are the two common categories, warm and wet and cold and wet. So these are actually managed differently. Right, so management we discussed. Okay, we discussed this also. If the blood pressure is little reasonable, this patient's blood pressure is low, so we were discussing about how to use an inotrope. If the blood pressure is normal or reasonably above 90, then you can use a vasodilator, and one of the students already said that, right? And if it is not improving, only use inotrope, right? And if these things, none of them are working, you have to go for a mechanical support, right? These are the practical points in using how to use an inotrope in heart failure. So I don't think that we need this one. Probably you have to know certain drugs in chronic heart failure, right? So actually this I wanted to show that beta blockers are overall benefit in heart failure, right? So there are three classes of drugs which are overall survival benefit. One is beta blocker. Other ones are
AC inhibitors.
Inhibitors or ARBs.
Spironolactone.
Yes, spironolactone, mineralocorticoid, and so those are the ones. Other things are of symptomatic benefit and just to tide over. So these inotropic drugs have not shown any benefit in the long term, reduction of mortality, but you might have to use it, right? So they are not of long term benefit, right? Okay, now I think we had enough discussion on the question. So shall we move to question number 2? Again, he's a 40-year-old man who came with exercise intolerance for 6 months. He was treated as exercise-induced asthma and was prescribed inhalers, but no improvement was noted. He has no chest pain. Examination, his pulse is 90, blood pressure 100/70, pedal edema present, JVP up the jaw, cardiac apex is 6 intercostal space, few rhonchi and crepitations were present in the chest. Grade 2/6 pan-systolic murmur was heard at the apex. Now we have already read this question earlier. So what could be the cause of this patient's problem? Is he also having some form of heart failure?
Yes.
Yes. Yes.
Chronic heart failure.
Congestive heart.
Failure due to
Congestive cardiac
mitral
failure.
failure.
Yes, congestive cardiac failure. Yes. JVP also elevated, pedal edema also present, so right heart seems to be failed, and cardiac apex 16 intercostal space, and he is having probably congestive cardiac failure. The duration exercise intolerance is 6 months, but we don't know how long, whether he had been asymptomatic. The 40-year-old man would have been asymptomatic for quite a while. So now maybe the chest was clear. That may be the reason why that he was treated as exercise-induced asthma, isn't it? It's very common thing to happen, isn't it? People sometimes use their stethoscopes very less, right? So probably these and also they don't examine the patient properly, so probably he was missed, right? So what could be the cause of this patient's heart failure? 40-year-old person, blood pressure is okay, so it can't be hypertension causing heart failure. He doesn't seem to be having any chest pain, so
Cardiomyopathy.
Valvular heart disease.
okay.
Fluid overload due to mitral regurgitation.
Volume overload due to mitral regurgitation. Grade 2/6 pan-systolic murmur was there. Okay. Grade
Cardiomyopathy.
cardiomyopathy.
MR and MS both could be there.
MR and MS both should be there.
Yes.
MR and MS both should be there for what? To have heart failure?
Yes.
Not necessarily, but this looks like a grade 2/6 pan-systolic murmur. It looks like a very low threshold pan-systolic murmur. Can you explain this murmur by any other mean? When the heart is too big, can you have murmurs?
VSD.
VSD person would have presented little earlier, no? Little earlier, and then this is at apex, definitely say. So VSDs are generally heard at the parasternal region and generally accompanied by a thrill and a pan-systolic murmur, and probably would have presented early, no? So this looks like this murmur looks like when the heart is too dilated, the valve rings also dilate. So therefore, this could be a functional murmur. It could be a functional murmur, right? Mitral regurgitation and sometimes even tricuspid regurgitation can happen. If the left ventricle is dilated, you can have a functional mitral regurgitation. That is why it is not a very loud murmur. It's a very 2/6 means it's not a very significantly loud, right? So this patient has heart failure and somebody said that already it could be cardiomyopathy, sir. Cardiomyopathy, okay. Dilated cardiomyopathy or hypertrophic cardiomyopathy?
Dilated cardiomyopathy.
Dilated cardiomyopathy is a possibility, right? So most likely it's a dilated cardiomyopathy. Can you think of a reason also?
Alcohol.
Of course, alcoholic cardiomyopathy. Definitely, alcohol could be. Chronic alcohol consumption could be. Chronic alcohol consumption causes heart disease and liver disease both together, right? Any other cause? Say I tell you that he has had a viral-like prolonged illness about 8 months back.
Myocarditis.
Viral myocarditis.
Yeah, viral myocarditis. What are the viruses which can cause viral myocarditis?
Cytomegalovirus.
Cytomegalovirus. Okay.
Coxsackie.
Coxsackie B. In fact, yes, Coxsackie is a possibility. COVID also causes myocarditis. COVID. Dengue can cause. Many viruses can cause Coxsackie B. Dengue, yeah, many viruses can. So it could be following a myocarditis. Anything else? Now alcohol, anything else? This kind of diseases are usually pretty much could be familial, right? Sometimes they have familial and there are so many various genes related to that, right? Anything else? Some other differential diagnosis? Say if this person is a lady who has delivered a baby. I had once seen a doctor who came to me with the same symptoms after her first baby, 3 months after. She has gross cardiomegaly.
Peripartum cardiomyopathy.
Exactly, peripartum cardiomyopathy, right? Or postpartum, before pregnancy or even after pregnancy. So peripartum cardiomyopathy is a possibility. If this patient is pretty much pigmented, right? And there was evidence of liver disease also. And the family history of a congenital, yes, hemochromatosis. Hemochromatosis is a possibility. Right? So we have 5-6 causes. Any other thing that you can think about? Say this is a person who had been, living alone in a curfew period, say couldn't go out, very barely had some food, and it is coming from a Sri Lankan word. Sri Lankan word.
Beriberi.
Beriberi cardiomyopathy. So nutritional deficiencies like selenium, vitamin B can cause, isn't it? This is due to which vitamin deficiency? What vitamin deficiency? Thiamine deficiency, isn't it? Thiamine deficiency. Thiamine deficiency is possible, right? Thiamine deficiency. So other things are like sarcoidosis, various other congenital syndromes. Drugs can cause, especially anthracycline, so many causes. So we will not go into detail of those. Right. So what does this show? We have discussed some ECGs. Yes, last time we discussed atrial fibrillation. So this, what does this look like? Looks like a QRS. You don't have to be so serious about things, and you don't have to be thinking too much. So what quickly can be spotted here is a
Widening of QRS complex.
widening of the QRS complex, very widening of the QRS complex, and in the patient is in a sinus rhythm, isn't it? Sinus rhythm rate is not too bad, a little bit high, but wide QRS complex with a V5, V6 has not been shown here. So, but I'm sorry, the ECG has got cut off. Look at this one, you can diagnose it already with this. This looks like a
Left axis deviation.
Tall tentative.
Axis deviation.
all entered T waves like
LVH.
this pattern is so LVH and all these tall entered T waves are not associated with a wide QRS. No, so first of all, think about a wide QRS complex is a bundle branch block, right? So first of all, use the most important thing in the ECG to figure out what it is. First of all, most important thing is the patient is in sinus rhythm, so there's no real arrhythmia going on, but the QRS is wide. So QRS is wide, QRS is wide because this bit is the conduction through the ventricle. Isn't it? This bit is the conduction through the ventricle, no? R and S and the Q. So if the conduction through the ventricle is blocked, this must be a bundle branch block, right? So this is a bundle branch block. Wide QRS complex with a RSR pattern. So V6 should look like this one. So I'm sorry, this has got cut off, I didn't notice. So V6 lead is like this one, right? RSR, slurred. There's a little notch here if you carefully look, right? So this is actually left bundle branch block pattern, right? Right bundle branch block pattern will have RSR in the V1. So even if you don't see that, you can't see a right bundle branch block here because there's no RSR here, right? So this is a left bundle branch block pattern. I think you can refer to certain books at some point. So why is the patient having left bundle branch block with this heart? One key thing to remember is if there's something wrong with the heart, the ECG is abnormal. If there's something wrong with the heart, the ECG is abnormal. You can't have a normal heart, very uncommon, I have normal heart and an abnormal ECG, right? So this ECG shows that something wrong with the ventricles wrong, something wrong. So it is actually could be a thing with dilated cardiomyopathy where the muscle is diseased, right? Muscle is diseased. So right bundle branch block, left bundle branch block. More than that, commonly atrial fibrillation are known arrhythmias with heart muscle disease. Cardiomyopathy is a heart muscle disease, no? So any arrhythmia can happen with a heart muscle disease, right? So etiologies we discussed. So what further questions and investigations are appropriate to find the etiology? We will come to that later. What is shown in the ECG is a complete left bundle branch block pattern. how you differentiate complete and incomplete is complete has at least 3 squares, incomplete has less than 3 squares but the same pattern, right? So somebody already said that the patient is in chronic heart failure. So let's manage this patient. So what are the drugs which are used for chronic heart failure? What are the drugs? Now 3 classes of drugs we know that they improve survival. So what are the 3 components that can be used in this patient?
AC inhibitors, beta blockers, spironolactone.
Those 3. Does he need a diuretic? When
Yes,
we,
madam.
yeah, if does he already has congestion, isn't it? He has congestion evidenced by raised JVP and peripheral edema. So probably in addition to mineralocorticoid, if the mineralocorticoids is settling that, you don't need additional drug, but he might need a small dose of a loop diuretic also. Right now he is 40 years old, right? If there's a reversible cause, we can reverse. So what further questions? Like you already said that alcohol is a possibility, right? Important. Hemochromatosis, family history, recent myocarditis and following myocarditis, or could be ischemic heart disease also, ischemic cardiomyopathy, but sometimes you don't get chest pain always, right? So these things are the questions to ask, right? So, and the drugs, infections, hereditary, any metabolic disorders. So those are the questions to check on. And substance abuse, not only alcohol, but cocaine. These also can cause. So appropriate investigations, I am sure you can list out appropriate investigations to find the etiology if you do a little homework. So now he has this bundle branch block. Is the left ventricular function going to be fantastic with a bundle branch block?
No.
So one bundle is, right bundle is probably in a, probably activating both ventricles because the left bundle is gone now. Left bundle is gone and the right bundle is working. So little asynchronous, no? Little asynchronous. So both ventricles may not be beating at the same proper timing, right? We are talking about fractions of seconds, right? Milliseconds. So is there any other better things that which can improve, used to improve? Yes? I didn't hear you well. If the left and these are not very big rocket science, right? So if the left and the right is not beating together, you can synchronize the beat. Synchronize, right? That is what? CRT, right? Cardiac resynchronization treatment or therapy, right? So where you pace the two ventricles, both ventricles are paced and atrium is also paced. So therefore, cardiac resynchronization will improve the cardiac output in this patient. Okay, now I am going to ask, if somebody has this kind of dilated heart, what can happen? Can they have arrhythmias? Can they have? Yes. So they are likely to have arrhythmias also. So patient can have an arrhythmic death, right? So therefore, the patient might need a Holter recording to record the arrhythmias and probably need a external cardioverter defibrillator, and those things can be done at the similar time. So just a little bit on device therapy, you don't have to go too much for this. So as I said, if the beta blocker is not reducing heart rate and controlling heart rate, you can use ivabradine. And also there are some other heart failure therapies that can be used. So mainly basically for this patient, other than medical therapy, there's a resynchronization therapy is needed. Right. So let's move on to the next question. Are there any questions with regard to that? You can ask if you have. Yes. Right. So let's move on to the next question then. Right. This is a patient who has hypertension, blood pressure 180 by 110, and shortness of breath, left ventricular hypertrophy.
Excuse me, madam.
Yes.
You didn't discuss the investigations for the second question.
I thought you could do it on your own. Right? So investigations, what will be the investigations like? So he will, let's look at the investigation. So he will need echocardiogram and status, and probably you will have to exclude coronary artery disease before you do anything. So probably he will need a coronary, most likely he will need a coronary angiogram to exclude ischemic heart disease for his cause of cardiomyopathy, because unless there's any obvious familial cause. If there's a very clear-cut familial cause, then other family members also have, you might not need to do that, but ischemic heart disease need exclusion, and then the depending on the certain things like, you know, checking on the iron level, right, liver functions, and then recording for arrhythmias. Other certain things are actually from the history, you know, like the nutritional deficiencies, alcohol, substance abuse, drugs. Those all come with the history, right? So in investigation wise, not too many. So what most important would be echocardiogram, coronary angiogram, and a arrhythmia screening will be needed. Cardiac catheterization, or sometimes you have to do a cardiac pressure monitoring also might be needed here. Like checking for pulmonary capillary wedge pressures. Those are little before you go for a advanced treatment. And then electrophysiological studies. So these are little advanced. So investigations could be investigations which are actually I want here is to find the etiology. So there are a set of investigations to find the etiology, and there are a set of investigations that you need to manage the patient. So etiological wise, checking for what I mentioned, coronary artery disease, hemochromatosis, those are the things, right? So I'm sure you can fill the gap for that. So let's go to the next question, otherwise we are losing time. So this patient with hypertension and heart failure, right? What are the drugs that you use in preferential drugs in hypertension associated with heart failure? There are certain drugs that you will use, and there are certain drugs you will not use. So what are the preferred agents for hypertension and heart failure?
ACEI.
ACE inhibitors, ARBs. Yes. What do you see? CCD. Do you get calcium channel blockers? Calcium channel blockers have no place in heart. Yes, please continue. So calcium channel blockers have no place in heart failure. So it could be actually detrimental to use something like a nifedipine, which are short-acting dihydropyridines. They are not used, but amlodipine, which are long-acting, can be used. But in this particular patient, this patient has hypertension and heart failure. So let's use the drugs which benefit both, right? So as you said, ACE inhibitors and beta blockers are useful for this patient, right? Any other drugs for survival benefit? It depends on the renal function. So she might have to, if there's heart failure, then probably you might have to use a not loop diuretic, but something which has shown survival benefit, like a mineralocorticoid, right? What about using HCT here? Those are common drugs for use for elderly people, right? For a period of time, it was the first choice. Anything else? HCT. So the diuretic that you would be using here could be HCT, which has dual benefit, right? It is a weak diuretic, but HCT, beta blocker, and an AC inhibitor are the main drugs that I really want you to consider on. Especially thinking about left ventricular hypertrophy, AC inhibitors is a must. Right? Any questions on this? So the management and the rest of things we already discussed: the acute heart failure with pulmonary congestion. We discussed a chronic heart failure. Now we are discussing a heart failure patient whose blood pressure is elevated. Right? Blood pressure is this a hypertensive emergency or an urgency? Do you need an urgent reduction of blood pressure using intravenous drugs? No. So how long will you take to do this?
48 hours.
Yeah, you can do it in days to week. Maybe take a week to control the blood pressure, because the patients already the regulation of blood pressure, it's in a higher level, auto-regulation, especially in the brain. So therefore, you might have to do it very slowly. So it is a hypertensive, not an emergency. It's an urgency. It can take time, and the patient can use oral drugs. And out of the oral drugs, these are the three main classes that you are going to use. If they are not responding to that, probably you might have to add on different classes of drugs, right? But calcium channel blockers are generally negative inotropic, and you won't be using, especially diltiazem, verapamil kind of drugs you are not going to use. If at all you are using, it could be something like a long-acting dihydropyridine drug, something like amlodipine or a felodipine, right? Any other question here? So we are not going to go through investigations in this patient. So let's move to the last case. Right. So the three beta blockers that are proven to be very effective in studies are carvedilol, metoprolol, and bisoprolol. Right? Carvedilol, metoprolol, and bisoprolol all are available in our country, and this is available in the hospital. I think metoprolol also now available in the hospital. So this case actually in this patient now heart failure has reduced ejection fraction, and heart failure sometimes have preserved ejection fraction, right? So this preserved ejection fraction, this component, actually this patient has left ventricular failure. Actually the patient probably has a diastolic dysfunction. Not all the patients have systolic dysfunction and low ejection fraction. Some people have diastolic dysfunction, and they have their systolic function is, ejection fraction is above 50. So people who have diastolic dysfunction, the three drugs I mentioned are the most useful, right? So heart failure is preserved ejection fraction, not reduced ejection fraction. Right. So this is the last case we will go through. I'm sure you have read this case already. She has breathlessness, tachycardia, which is irregular, tremulous, sweaty, cardiac apex is deviated, high ejection fraction. What does this patient have?
High output cardiac.
Can you repeat it?
High output cardiac failure.
High output cardiac failure. Exactly. What is the most likely cause?
Thyrotoxicosis.
Toxicosis.
Thyrotoxicosis. He's got the tachycardia, irregular pulse, hands were tremulous and sweaty, cardiomegaly is there, and ejection fraction is high. So high output heart failure. High output heart failure due to thyrotoxicosis. Right? So additional symptom and signs we are not going to discuss here. I'm sure you know already. How do you confirm thyrotoxicosis? Okay, what is the most important physical sign in thyrotoxicosis? If you are allowed to do one physical sign to confirm that this one is thyrotoxic, what would you do? Have a guess.
Reflex.
Reflex could be, but most importantly, the lead is in the thyroid node, yes, isn't it? So if the lead is in the thyroid and it is toxic, what is the physical sign?
goiter.
Thyroid thrill.
Very good. Yeah, goiter could be there, but a thrill and a bruit in the thyroid is the most important sign, right? Thrill and a bruit, thyroid, right? Thyroid bruit and a thrill, it definitely tells that the patient is toxic, right? So confirmation is by checking for thyroid function test, right? So T3, T4 will be elevated and the TSH is pretty much suppressed, right? So management, how do you manage this patient? Now it's got a heart rate of 140. What are the drugs? She is in AF. Because some drugs I did not discuss with. I want to discuss a drug with you here. AF and AF. He has heart failure because heart is enlarged. AF, heart failure and tachycardia. What is the drug?
Digoxin.
Very correct. Digoxin. Digoxin. This is a situation where you use digoxin. Digoxin is not much used in heart failure. But what the study says, if there's atrial fibrillation and heart failure, it is a very useful drug. And people who are on digoxin, you should not withdraw because digoxin withdrawal will have increased mortality. Right? But digoxin is not much used in heart failure as isolated drug, but this is a situation it can be used, right? Digoxin. In addition to digoxin, the heart failure treatment is with beta blockers. So beta blocker is a must here. So beta blocker, what kind of beta blocker would you select? A selective beta blocker or a non-selective beta blocker? Selective or a non-selective beta blocker? Say if I tell you
Non-selective.
Non-selective. Why do you want to select a non-selective beta blocker here? Yes?
To inhibit the peripheral conversion?
Yes. To inhibit the peripheral conversion also there's a benefit, but more than that, it will be useful for tremors. Isn't it? It will be very useful for the peripheral effects of thyroxine. So tremors, sweating, they are very anxious, isn't it? They are very anxious, really colorable, and those will be really reduced by using a propranolol. Listen, some students take it before going for the exam because it is actually, propranolol is a little anxiolytic, isn't it? Anxiolytic. So non-selective beta blocker like a propranolol will be very useful here. Digoxin will be useful here. What is the other drug which will be needed here to control this thyroid status? Is thyrotoxic.
Calcium channel.
Propyl thiouracil.
Yeah, carbimazole or propyl thiouracil, isn't it? If the carbimazole is contraindicated, then propyl thiouracil, either of that. So there's no real benefit over one over the other, but in certain situations like a pregnancy, you will use PTU than carbimazole. So carbimazole is, how do you use carbimazole? High dose or a low dose, or how do you start carbimazole? Yes.
High dose and
High
reduce.
dose.
Yeah,
High
absolutely.
loading dose and
Very good, very good. So we use about 45 milligrams of carbimazole. That's about 9 tablets, 8-9 tablets. And then, of course, you reduce it depending on the response. So slowly you will have to reduce it, monitoring the thyroid function over weeks to months, right? Over week to month. General maintenance dose about 10 milligrams. So if you do it fast, if you reduce it fast, the patient will have a toxic relapse. If you do it, keep it going on too long, it will have the patient will become hypothyroid. So these are the things that I think we covered most of the drugs and management in heart failure. People who can't take ACE inhibitors, what are the things that can be given? Intravenous?
Hydrogen plus nitrate.
Yeah, hydrogen plus nitrate reduces. Hydrogen is what? Is a arterial dilator and nitrate is a venodilator. So in combination, you are reducing the preload. So that is how it works. So In people who can't use, that is a drug to use as intravenous. And then there is these BNP can we use BNP usefully for something? BNP is brain natriuretic peptide. Natriuresis means sodium and water is cleared. So they are actually naturally acting kind of diuretic hormones. So these drugs also these hormones also can be used if you can reduce BNP breakdown, right? It could be used, right? So there are sacubitril plus valsartan. Again, because the sacubitril will inhibit breakdown of BNP and also AC. So therefore, you have to combine it with the AC inhibitor, right? Those are the newer drugs which are in use. But if somebody asks, I thought I'll rather tell you. So I think we have covered most of the drugs. If there are any other questions, you can ask me now. It's okay to ask any form of difficulties or any doubts that you have. Right.
Excuse me, madam.
Yes, dear.
Madam, in managing this thyrotoxicosis as the first line therapy, do we have to start the patient on fluid therapy or?
Fluid therapy? Yeah, I would give an answer like this. So if the patient is having, these people are very warm, they have sometimes fever, sometimes they are in a thyroid storm, right? If that case, definitely fluid and a cooling blanket, right? Cooling, some way of cooling and fluid, yes. Depends on their hydration status. Right? Intravenous fluid, depending on how bad the patient's situation is. If the patient has, we were discussing, is the congested and this wet, right? So if they are wet, no. If they are dry, in heart failure also, sometimes you might have to use a little bit of fluid with caution. I didn't want to tell these things because it might confuse some of you, and then you will give a wrong answer when it is needed, right? But there are, so we will only concentrate on the wet people who are congested, but there are dry people also, right? So heart failure is a very wide spectrum. So in certain situations, as you said, give some fluid. Yes, it may be correct, but depending on whether the patient is fluid overloaded or not, or in other words, wet or not. Is that okay? But then definitely in a thyrotoxic crisis, you might have to give fluid and also to cool the patient and different things like a storm, because they are very febrile, and there's definitely loss of fluid through the skin, sweaty and febrile. Does it mean anything? Is it explanatory enough?
Yes, madam. Thank you, madam.
Excuse me, madam.
Yes, dear.
Does nitrates and hydrazine also have some place in survival benefit for heart failure?
Seems like. In some studies, yes, but very not yet confirmed. Like.
Then, if it appear in an MCQ, can we take it as correct or?
I'm not sure about it. I won't mark that.
Okay, madam. Thank you.
Anything else? Right.
Madam, excuse me.
Good.
Madam, I have a question about that salvageable myocardium, madam. What is the hibernating and stunted myocardium, madam?
Right. It is something like this. When you have no blood coming to it's just like think about some plant. Now we are growing things. Now think about certain things like some say patch of land or grass or whatever. When there's no water, it will kind of dry up. When you water it, it will rebloom again. When you don't have water, it's like a dried or a dead one, which is almost non-functional. So heart is also like that. If you have no blood supply to certain areas, they just sleep. Hibernation means that. Hibernating, hibernating animals and all. So when you revascularize it, it will start functioning back again, right? Stunned myocardium is also similar, chronically stunned because of chronic ischemia. Chronic ischemia and the patient with revascularization, there's function. So that is what it means.
Okay, thank you, madam.
Right. So in the absence of other questions, we will meet at some other, again, similar session. So thank you very much for attending. So
Thank you, madam.
Thank you, madam.
Okay.